This conference will now be recorded.
Yeah, hello, good morning all. Am I audible? Am I audible, guys? Hello? I think. Hello? Somebody? Somebody
Yes,
give a go. Yeah. Oh, thank you, thank you. So shall we start? So it is 9:30 and 93 and counting. So yeah, sorry, 10:30. So yeah, we'll start. Okay. Today's topic is about care of low birth weight babies. Okay, the commonly colloquially called LBW babies. Okay, low birth weight, and yeah, we'll be discussing about only the low birth weight, and there are things called extremely low birth weight, and those things less than 1,000 grams is extremely low birth weight, and very low birth weight is less than 1,500 grams. And now we are doing only, I mean, along with that, low birth weight is anything less than 2.5 kgs. Okay, 2,500 grams. Okay, this is our topic, because these babies are less weight, obviously, so they need extra care because they'll be losing more compared to others, term babies or uh, of good weight. And these babies will be having higher susceptibility for hypothermia, infections, and whatnot, everything. Okay, so care of these LBW babies are of concern, and yes, we have to deal with caution. Okay, so the topic, care of low birth weight babies. Yep. Okay, as we discussed, the definition is purely birth weight less than 2,500 gram, that is 2.5 kg. And okay, yeah, somebody, there is disturbance. Yeah, somebody's speaker is on, I think, unmuted. Okay, okay, yeah. So the incidence is 30% of neonates in India. Okay, because the factors are maternal factors and fetal, mostly maternal factors. Mothers, they are not fine, so they give well nutrition uh, diet is not there, so maybe mother is giving a LBW baby. Okay, 75% neonatal deaths and 50% of neonatal, I mean, infant deaths occur which belong to LBW. So this is the reason why we need to take extra care and caution, because a large number of neonatal deaths, and even after the neonatal period, that is up to 1 year of age, they still carry the onus of this low birth weight, and there is a 50% infant deaths because of low birth weight infants. Okay, so we need to take extra care, and the babies are more prone to, why do they do this, I mean, why they having a lot of morbidity and mortality is because of malnutrition and recurrent infections and neurodevelopmental delay. Okay, uh, yeah, yeah, as we go by, they're mostly low birth weight. The weight is low because the two main reasons why there is low birth weight: either the dates are less, like they are premature, or the dates are good but the baby's growth is not good. Okay, in either way, there is trouble with the baby. And because a 2.5 kg physiology is very hard to manage than a term baby of 3 kg or 3.5 kg. Okay, a 2 kg baby is really very difficult to deal with. Okay, because of the risks of malnutrition and the recurrent infections, because they'll be like sitting ducks, because they they don't have good immunity, they don't have good nutrition, they'll be not gaining weight, and they'll be just attracting all the infections. Again, neurodevelopmental delay is because of the hit on the brain, and the rapidly growing part is the brain. So when malnutrition is there and the brain is actively growing, the development gets hit. Okay, Yeah, this is because of the higher mortality and morbidity is common. Okay, the types of LBW, low birth weight babies, as we discussed, there are two main reasons basically. Either it is a preterm because the dates are less, so the babies has not grown to the level of a term baby or a complete 3 kg or 3.5 kg. And another thing is small for the dates. The dates are good, the baby is term, but the baby hasn't grown well in the mother. I mean, the mother has not taken proper care, or the baby inside the womb, the baby hasn't grown well because of different reasons, be it infection or malform, whatever be it. Okay, coming to the preterms, it is by definition less than 37 completed weeks. The word is important. Completed weeks is important. 37 plus 1 and 37 0 by 7. Okay, 0 by 7 is the term date, and anything less than 37 0 by 7, that is 36 6 by 7, is also a preterm. Okay, so the definition is important. 37 is the number. Okay, and then they do account for one third of the LBWs, and most of the LBWs are term, but they haven't grown well. They are called small for dates, or IUGR, intrauterine growth retardation. As the name suggests, it is intrauterine growth retardation. In the uterus, the baby has to grow for 9 months or the 36 week or 37 week, but the baby hasn't grown well inside the uterus. So the name intrauterine growth retardation. Okay, by definition, it is less than 10th centile for gestational age. See, uh, like the children we take for the centiles after birth, they are intrauterine growth charts. Those are called Fenton's charts, and 21. Okay, 21 growth charts. So these charts specify how should the fetus grow in the womb, like in the uterus, so that what is normal. Based on that, they'll plot the percentile charts. In that, if the percentile is, if the growth is less than the 10th percentile in those charts, then we'll be dealing the charts also. uh, Remember, the number is less than 10th centile for gestational age. Okay, a 20 weeker comes, you do the scan and you find the weight of the baby, you estimate the weight of the baby, you estimate the length and all other dimensions, femur length and your biparietal diameter. Okay, yeah, those do tell you at what percentile the baby is in. Okay, and they account mostly in LBWs, they account the large chunk of it, because in 2/3 of them you do this. Okay, yeah, coming to the etiology of prematurity, why should the baby be delivered prematurely less than 37 completed weeks, is because of low maternal weight. If the mom is not doing well, mom is a teenager, mom herself is not nutrition, I mean, nourished properly, and there are multiple pregnancies, there is no reserve for the mom to make a well baby, and the spacing is, all these constitute to a prematurity. And then previous preterm baby, by statistics, will have a high, I mean, recurrence rate of prematurity. And cervical incompetence, as it is second trimester, there's a higher chance of induced. So somebody's mic is on. Please check. Maybe the other side is, guys, somebody can. Okay, I think it is KS1. I don't know who is KS1. KS1. K Santoshi. I don't know. K Santoshi. I think. Yeah. Okay. Yeah. Coming to the topic. Yeah. Previous preterm baby and cervical incompetence was also a risk factor for premature, and antepartum hemorrhage because of the placental bleed. The placenta is not attached properly, and improper attached placenta will give improper nutrition to the fetus. So that will cause prematurity, and acute systemic diseases of the mother. And induced premature delivery because of different factors. If the mother is sick and have to deliver the baby, then induced premature delivery can also cause prematurity. And in majority of the cases, it is idiopathic. Nobody knows the cause. They just deliver prematurely. That is majority is unknown. Okay, these are the conditions. In coming to the etiology of small for gestation, small for age, and what is IUGR, intrauterine growth factor? Then why should a baby, a term baby or a 40 weeker, why should a 40 weeker be of less weight? Is because poor nutritional status of the mother. Hypertension causes vascular vasoconstriction. Vasoconstriction will lead to decreased nutrition to the baby and decreased growth, and toxemias and any infection and anemia of the mother. And during multiple pregnancies like twins, triplets and quadruplets, all the and these conditions, the mother reserved nutrition has to be divided to the all the babies, so obviously they won't be growing properly. And post maturity, once the baby matures and the baby starts using its own energy, so comes down, weight comes down. And chronic malaria is all the chronic infections like to the mom. Chronic malaria, chronic illnesses, and tobacco use is one of the cause where the baby fetus doesn't grow well. Again, it is because of the vasoconstriction and proper improper nutrition to the fetus. Okay, now identifying the type of see, this will be mostly to sensitize you regarding a preterm and a term, because as a undergrad, you just there'll be photographs, so that we'll be dealing with just to get sensitized. Okay, this is not a big thing to discuss, but you should be knowing, because you may be having kids at home or somebody, so you should be knowing what is a preterm, what is a IUGR, so that it feels good, right? So it's good to know. And also to sensitize you, I want to think of some theory topic. This is of some theoretical importance than practical. No, I don't think much of in Viva they may ask, but not in much of practicals. But in theory, care of newborn and feeding of newborn may be a question for you. Yeah, identifying the types. You know, prematurity. How do you identify a premature from a term baby or a IUGR? You know that you once the baby is born, you go check the weight. The weight is 2.2 kg, which is less than 2.5. So you now you want to see whether it is a premature or a intrauterine growth retarded baby. Like you want to know that whether the baby has grown well, or has the baby is not up to the date. Okay, that is how you do that, because first thing you do is your dates. Okay, date of last LMP, and you check the dates with your gynecologist or your obstetrician and obstetrician help. Then you calculate the dates whether the baby is of term or whether have completed 37 weeks or haven't completed 37 weeks. Okay, that is how you identify. The next thing is you just see the baby. There are four cardinal things you need to see. There are a lot of things. Your modified Ballard scoring is based on this, but primarily for you guys, it is four things you see, so that you strikingly you can identify that whether a baby is preterm or a term baby. That is your breast nodule, genitalia, sole creases, and ear cartilage or ear recoil. Okay, this is what we see. Okay, this is your breast nodule. On the left you can see, if the pointer you can identify the left, you can see that the breast nodule is not well formed. The nipple is not well formed. The areola is just skin colored, and which is just camouflaged into the surroundings. So this is a preterm breast nodule. Okay, whereas a term breast nodule, which is seen on the right side, a well-formed areola around, that is darkened areola, and the nipple is also well formed and identifiable. Like a nodule, it is identifiable. Okay, this is a term a breast nodule. This is a preterm breast nodule. Okay, coming to the genitalia, that is another important factor that we can see. Male genitalia and female genitalia. In male genitalia, you can see that there is a loss of, there are no rugae that is formed. It is skin colored scrotum, and there, if most probably the testis wouldn't be descended, and you need to check for it. Okay, and undescended testis, which may be in the inguinal canal or during the passage of the process vaginalis. Okay, this is a term male genitalia where there is darkened skin with a lot of rugae present, and this constitutes your term male genitalia, and this is your preterm genitalia. Okay, this is your female genitalia. Strikingly, preterm, the minora is not well covered, and clitoris and these are appear more bigger. So this is your preterm, and in a term, your labia minoras and majoras, minora will be tucked in, and your majora will be bigger than your minora. Uh, so, and clitoris regresses back. So this is your term female genitalia. And coming to the sole creases, smooth and with a less number of creases is a characteristic feature of pretermity, and a well formed creases all over the sole is a feature of a term baby. Okay, yeah. Coming to the small for dates or small for gestational age and IUGR, intrauterine growth retardation. IUGR, these can be, as we discussed about, we do by charts, like whether the baby is falling below the 10th centile. Okay, remember the numbers. Okay, 10th centile, less than 10th centile, that is your IUGR. And how do you identify? Is my physical characteristic the same way? Physical characteristic, because when you do all these things in a breast nodule, your genitalia, and this thing, and ear cartilage, yeah, we missed ear cartilage. Ear cartilage will be very soft and pliable in case of preterm, and a well formed ear cartilage in a term baby, and recoil will be very fast in case of term, and recoil will be slow in case of preterm. That is regarding the ear cartilage. Okay, yeah, all these things you see that is a term baby, but a 2.2 kg, a term looking baby. So what are you going to look extra for to know for an IUGR? Okay, it is emaciated look, loose folds of skin, like there is my old man's appearance of the baby will be, we have an idea about the babies, right? Plumpy, chubby baby, but the baby won't be looking like that. There'll be baby like a emaciated, dull, a lot of skin folds present on the baby, and all these constitutes your IUGR. The baby hasn't grown well in the uterus. Okay, lack of subcutaneous tissue, and head bigger than the chest by more than 3 centimeters. Okay, normally 3 centimeters, but if it is more than 3 centimeters, that constitutes your IUGR. Okay, this is how to identify an IUGR. And normal baby, see, this is a 2.1 kg but a term baby. You can see the breast nodule is well formed, and you can identify the breast nodule. Genitalia not visible, but this well formed genitalia, the head appears bigger than the body, and there are a lot of skin folds. You can see the baby is emaciated, like very thin, emaciated, not the look we expect in a newborn, right? And on the contrary, you can see a term baby with 3.2 kg, a well-formed baby, where there is a good amount of subcutaneous fat. The baby is chubby. Of course, there are rugae, dark genitalia, and well-formed breast nodule, and good ear cartilage and everything. But the baby appears chubby and this thing. Okay, this is the difference. Yeah, this is the chart we have been discussing about regarding IUGRs. See, this is plotted on the birth weight and the gestational weeks. Okay, from 31 to 37 weeker, as we discussed, 37 weeker it is preterm, from 37 to 42 it is term, and more than 42 it is postterm. This is the weekers. Okay, and this is the weights. Okay, this is the 10th centile chart, and this is the 90th centile graph. Okay, so if it is more than 90th centile, it is large for dates, macrosomic babies, big babies. And if it is less than 10 centile, as we discussed, in a term it is IUGRs, in a preterm obviously it is a preterm. Okay, when it falls in between a term baby, when it falls in between 10th and 90th centile, it is appropriate for dates or appropriate for gestational age. Okay, this is how the thing goes. You just remember these things: 10th centile and 90th centile. More than 90th centile a big baby, less than 10th centile it is an IUGR in case of a term babies. Okay, and a preterm, remember that even preterms can be large for age. Okay, this graph the most important, but you don't undergrad, you don't get confused with all these things. Just do this 90th centile, 10th centile, less than this, and in between is your appropriate for age. Okay, now coming to the problems. So what is this lot of Allah about this low birth weight babies, and what are the problems? Okay, the problems could be birth asphyxia, hypothermia and feeding difficulties, infections, and susceptibility to infections, and hyperbilirubinemia and respiratory distress. All these can be happening in case of a preterm. Okay, and in when you treat it, retinopathy of prematurity can happen, and apneic spells can be present, and intraventricular hemorrhages are a risk factor in a case of preterm. Hypoglycemia and metabolic acidosis, all these can be risk factors. Okay, and coming to the small for gestational age issues, same thing, birth asphyxia can be a cause. Meconium aspiration syndrome, because it's a term baby, meconium aspiration is very common in case of a term and post terms. And hypothermia, because the weight is less. Hypoglycemia, because there is less glucose stores. Infections, yes, because less weight, less immunity, and less fighting capacity. And polycythemias. Okay, remember, this is polycythemia is a risk factor in case of a IUGRs. Okay, issues in delivery, during delivery, transfer mother to a well-equipped center. Neonatologist or a pediatrician assisted delivery should be there, and a backup, an ICU backup should be there, where the mother has to deliver the baby, because we are expecting a baby who is less weight. Okay, and a skilled person needed for effective resuscitation. A pediatrician should attend, and prevention of hypothermia is the topmost priority, because less weight, they'll lose more temperature, they'll be losing more easily, and they'll be very much susceptible for hypothermia and infections subsequently. Okay, indications of hospitalization. No, yeah, okay, once the baby is born, baby is not of good weight, so how are you, what is the criteria you follow to admit the baby, or whether to discharge the baby, and whether to keep the baby with the mother? Okay, the criteria is, if the birth weight is less than 1.8 kg, that is 1800 grams, and if the gestational age is less than 34 weeks, you have to keep it in NICU. If the baby is unable to feed, and in a sick baby, because birth asphyxia, meconium aspiration, all these things can happen. So if the baby is sick, you have to put it in the hospital. Okay, and unable to feed, even if the baby is 2.4 kg, you have to keep it in the ICU. Even if the baby is a term baby, and if the baby is not feeding well, you have to put it in ICU. That is common sense, right? If the baby is not doing well on its own, so you may have to take under care. Okay, and sick neonates, obviously, if you're suspecting infection, sepsis, whatever be the weight and the gestational age, you have to put it in an ICU. But remember these numbers again, less than 34 weeker, you have to put it in ICU, irrespective of whatever the baby is. Baby is active, feeding well, whatever. But if the baby is less than 34 weeks, put it in ICU. A baby is feeding well, active, whatever, blah, blah stuff. But the baby is less than 1.8 kg, put it in ICU. Okay. This is the criteria for hospitalization. And once you give it to the mother, and what you have to tell is warm at home. This is your KMC, skin to skin contact, kangaroo mother care, where both chests should be bare, and the baby has to be put in between the breasts of the mother or father or anybody, any caregiver. Oh, so yeah, and there are few justified room temperatures at home for the body weight. Okay, if it's more than 2.5 kg, that is a term baby or an AGA. It is 28 to 30 degrees room temperature should be maintained, and 2 to 2.5, 30 to 32, and 1.5 to 2 kg, it is 32 to 34 degrees centigrade. And if the baby is 1 to 1.5, the room temperature or the warmer or NICU, the ambient temperature should be around 34 to 35. As you can see, the temperature is increasing when the baby's weight is decreasing, because babies will be losing more heat, which is not good. Baby will be using all its calories to produce the heat alone. So you need to supplement the heat properly, so that the baby will use its calories, whichever the baby is having, to grow and to gain weight, and to get into the term things. Okay, so how do we have to prevent the heat losses? The heat losses are of 4 ways, that is radiation, evaporation, conduction, and convection. This is your question. a small short note. This is radiation, evaporation, conduction, and convection. Okay, all these things are the 4 ways by which a baby can lose its weight, or even we can lose the weight. Okay, to fight this, we have to wrap the baby properly, and the baby has to be kept in a warm room. Okay, and as this constitutes your son. Okay, convection is first coming to the radiation. Radiation is anything hot compared to the surroundings will be losing heat, that is through radiation. Okay, if you keep a 10-degree object around a 30-degree place, the 10-degree will be getting hotter and the 30-degree will be coming cold. Okay, they just radiate heat. Okay, that is through radiation. You, me, everybody, you and I, everybody do that, radiates heat. Okay, and then what is convection? Convection is because of the air currents that is blowing around it. Okay, that is how you feel the cold when the fan is on. Okay, it's because of convection. Your heat that is getting radiated from you will be removed by the air current, and a fresh less temperature heat air comes, so that you will start heat that also. So again, that is how you are constantly losing heat, that is convection. And evaporation, once you sweat or anything gets soaked or soiled, once the water gets evaporated, you will get a cold surface. Okay, that is evaporation. Okay, and another thing is conduction. Conduction is anything surface to surface. If a warm object is attached to a cold object, the cold object gets warmed and warm objects gets cold. Okay, that is your conduction. That is how you lose. When the baby, in context of the baby, you'll be losing, the baby will be losing heat to the other surroundings, the warmer bed, and the other caregiver's hand, and all these things. Okay, these are the 4 things. Okay, radiation, loss of heat, convection by air currents, evaporation by water evaporating or soiled or anything, and conduction into the contact. Okay, this is a well wrapped covered babies. This is a twin and multiple gestation. Obviously they are less body less weighted, but they're term babies. So this is how they take care of the babies, to cover the babies properly without any visible hands. Head caps are there, mittens, socks, mittens should be there, and a well wrapped baby. Okay, okay, coming to these incubators and warmers, because a lot of colloquially outside there will be a lot of confusion regarding what is a warmer and what is an incubator. Okay, this is a radiant warmer. This you can see in the ICUs. This is a radiant warmer, and this is an incubator. Incubator is completely sealed and extremely low birth weight. We do this so that your convection is not there. There is no air currents that is flowing. It is an environment by its own. Okay, like the uterus, it is the environment by its own. There will be warm air that is flowing in and out. Okay, and these are the ports to intervene. You can put hands into this and you can manage the baby. Okay, this is an incubator, air heated incubator, and this is the radiant warmer. Okay, here the baby will be open, like the air currents can pass here and here, but here nothing will be there. Okay, yeah, yeah, coming to the management, how do you do this? How do you feed a baby of low birth weight? How do you take care of the baby of low birth weight and all these things? Okay, it is mainly starts with the fluids. Okay, because what we think is a less kg baby, you give less fluids. That is a common sense, but the thing is, the low birth weight babies, they'll be losing a lot of heat through evaporation and all these things. So we may have to do more fluids compared to a term baby. Okay, remember, there is a catch in this. You have to do more fluids, and you need to look for proper, because they'll be losing more, and also they're having less of fluids, so the weight. Okay, so if the weight is less than 1200 grams and gestation is less than 30, then you can try gavage feeds if the baby is not sick. Okay, and the baby is actively taking, if the baby can suck well, because a 28 weeker can start sucking. Okay, and by 32 weeks swallowing and sucking will be good, and by 34 weeks swallowing and sucking will get properly coordinated. So if the baby is around 30 weeks, if the baby is okay to, I mean, having a good suck or this thing, I mean, there are not of much of suck for the baby, so we may have to give feeds externally. Because for a suck and swallow, at least the baby should be around 32 weeks or above. Okay, and the perfect coordination will be at 34 weeks. So you can't give an external feed up to 34 weeks. That is the reason why we keep the babies in NICU if the baby is less than 34 weeks, because the baby by itself cannot suck, swallow, and have a good coordination. Okay, so unless if the baby, we get a baby less than 30 weeker or something, so we do gavage feeds. Gavage feeds is you putting in OG or nasogastric tube or orogastric tube from the mouth or the nose into the stomach, and you directly push feed into the stomach, so that the baby need not have to suck, swallow and all. You directly put milk into the stomach so that the baby starts digesting it. Okay, that is your gavage feedings. Okay, yeah, start initially IV fluids. You know, first you do IV fluids, then this thing, because the baby may not be tolerant in feeds, so start IV fluids. Introduce gavage feeds once stable, because these babies will be having birth asphyxias or other comorbid conditions. So you do the comorbid conditions and then you do the initial gavage feeds. Okay, and shift to katoris or spoon feeds over next few days. Later on breastfeeds, you know, slowly, if the baby is tolerating gavage feeds well, and slowly the age is increasing in an ICU and the baby is also constantly gaining weight, then we'll be trying your katori. Katori is like that uggigini we say, that spoon feed or the katori, which I'll have the pics. I have the pics, we'll see. Okay, you do the feed. Okay, what is the difference between a gavage and a katori is, for a katori the baby has to swallow. Okay, yes, the baby has to take the milk and also the baby has to swallow, and once the baby is doing katori or palade or your spoon feed, whatever it is, then we'll go into the breastfeed. Okay, slowly we'll do non-nutritive sucking. Once we'll see, we will put the baby on the mother's breast and see how the baby is suckling on the breast. If the baby is suckling well, then we will just give the baby to the mother and try for the breastfeeds. Okay, this is the thing we follow regarding the feeding of a low birth weight baby. Okay, if the baby is a bit higher weight, okay, 1200 to 1800 grams, the baby is of some better weight, and the gestation is 30 to 34 weeks as we discussed. You start with gavage feeds. If the gavage feeds are okay, within 1 to 23 days, you start with your katori or spoon feeds. That is your palade, katori or spoon, whatever it is. You start with these feeds and then shift to breastfeeding once the baby is stable and able to suck well. Okay, and these babies can also need IV fluids, because initially you do IV because you're not going to make the baby hypoglycemic, so you start IV fluids and then game on the feeding. Okay, not directly game on the feeding that yeah, baby is 34 weeker, the baby has to take, baby may be sick with other comorbidities, baby may not be feeding well, so start with IV fluids, then gavage, try gavage is tolerating well, then you do katori or spoon. Baby is doing well with katori and having good suck, then you put it on the breast and then feed the baby through breastfeeding. Okay, this is the norms we follow. And if the baby is more than 1800 grams and gestation is 34 weeks, then you know that the 34 weeker will have good sucking and swallowing and coordination. Then you can directly start putting on the child to the breastfeed, or you can do the katori or spoon feed if sucking is not satisfactory on the breast. And then once you feel like the sucking is good, then you can shift it to the breast. Okay, this is basically how the feeding pattern goes on. Okay, yeah, feeding schedule, begin with 60 to 80 ml per kg per day. If there's 1.5 kg, you do 90 ml per day in divided doses. Every 2 hours you will be feeding, then you will do 90 ml by 12. You see what is the math, around 9 ml or 10 ml per feed every 2 hours. Okay, this is how we do feeding. Okay, increase by 15 ml per kg per day. Like today if you are giving 90, you just give some 100 ml per kg tomorrow, like that. Slowly you increase the feeds. Okay, maximum till 200 ml per kg if the baby is reaching, that is the maximum. Okay, and then first feed at 2 hours, 2 hours of age, then every 2 hour feed has to be given, and all through the night also. Okay, the important thing is babies won't sleep like us from night 11 to 7 or whatever the time be. So babies, it is 24 hours. Every 2 hours, if the baby is sleeping also, you have to get up, wake the baby up, and then feed the baby every 2 hours. Okay, this is your gavage feed, and this is a common sight if you are in NSU, or if you haven't been to NSU, or anyway you will be seeing in NSU. Okay, this is the gavage feed. The tube is inserted into the mouth. In this case, this is orogastric tube, and then the milk is directly put into the tube. Okay, this will be done in less than 30 kg or weight less than 1.8 kg or in a sick babies. Okay, this is your woogie, this katori, spoon, palade, whatever it is. Okay, here we want to see we are based on the swallowing capacity of the baby, because we're putting the milk only in the mouth, and from mouth the baby's job, it is the baby's hands to swallow the milk to the stomach. Okay, this is your katori feeds. Okay, IV fluids, nothing more to discuss. IV fluids and breastfeeding, right? The two extremities, I think we need not. Okay, and now coming to the fluid, this thing, fluid requirements. As we discussed, there will be more fluid requirements than a higher baby. As the body weight comes down, you may have to give more fluids because they'll be using more fluids. Okay, on day 1 of life, if it is more than 1.5 kg, it is 60 ml per kg. This is ml per kg per day. Okay, and if the weight is less, that is 1000 to 1500 grams, it is 80 ml per kg. And the second day it is 75. In case of more than 1.5 kg, it is 95 ml per kg if it is 1 to 1.5 kg. On day 3 it is 90 ml per kg, and in 1000 to 1500 it is 110 ml per kg per day. Day 4 it is 105, 125. 5 is 120. Just remember, I think these numericals are not much the same, but just remember that you may have to do more fluids, that is 10% more fluids in case of a less body weighted. Okay, and by 7th day it is 150 ml per kg for both almost. Okay, yeah, guidelines for fluid requirement, that is what we have discussed. It is first day it is 60 to 80 ml per kg per day, and daily increments of 15 ml per kg till day 7, and add extra 20 to 30, 20 to 30 ml for infants under radiant warmer, and 15 ml per kg in those receiving phototherapy. This is just if the baby is having hyperbilirubinemia, you add more fluids, because again it is a lot of heat, and the baby will be losing a lot of water evaporation. So we may have to do more fluids than the normal basic 60 to 80 ml per kg. Okay, and adequacy of nutrition, like how to identify that whether the baby is doing well with the treatment or the protocol which we are following. It is through weight pattern. You will see the weight, how the baby is getting, and yeah, babies should normally lose 1 to 2 kg weight every day initially, and the cumulative weight loss of 10% is acceptable. And if it is more than, you may have to attend whether something is going wrong with the baby. And in case of preterms, it can be no more than 10% of the body cumulative body weight. What is 10% of cumulative body weight mean is, you imagine that the baby is a 2 kg baby, that is 2000 grams. 10% in 2000 is 200. The baby is not allowed to lose more than 200 grams. Normally babies lose weight in the first 10 days, right? 1 week to 10 days, that is normal, where the intracellular and extracellular fluid gets exchanged. So normal loss of weight is not usual in the first initial days of life, till it is 10% of its initial body weight, that is your cumulative weight loss, that is 10%. Okay, in case of preterm, it can be more, like 10 to 14% can be there. Okay, and body weight has to regain by 10 to 14 days of life, and then gains up to 1 to 1.5% of body weight daily. Okay, in rough method, for the first 2 to 3 months, it should be like 20 to 30 grams per day. The baby has to grow in case of term and preterm also. Okay, and excessive loss or inadequate weight, you may have to think of cold stress, anemia, poor intake, and sepsis. The baby is not gaining weight, and there is excessive losing weight, and then something is going wrong with the baby. What all things can go wrong is cold stress, the baby is not kept warm properly, and anemia, the nutrition is not getting transported properly through the tissues because of anemia. And there is poor intake, in the feed itself is diluted feed, or the feeding practices are not good, or the baby is not fed every 2 hours. The baby is feeding haphazardly. And sepsis, something is eating up your calories in the baby. Okay, and in case of small for gestational age, babies doesn't lose weight, okay, because already the baby has lost weight. Intrauterine growth retardation, already the baby has lost considerable of weight, and there is no subcutaneous fat, much of reserves present in the baby to lose. So there will be no normal weight loss may not be there. And coming to the other supplementations, and what all you can supplement other than the mother's milk or breast milk is your you need to fortify with vitamins. Vitamin K 1 mg per at birth has to be given, and vitamin A 1000 international units per day, and vitamin D 400 international units per day has to be given over months. You have to give this. In case of vitamin D, it is up to 1 year of age. Okay, iron supplementation, it is 2 mg per kg per day from 8 weeks of age. It's not immediately after birth, it is after 2 months after birth. Okay, iron, because it itself can cause gastritis and other intestinal bleeds and other stuff. So you allow the baby to grow well, and you do iron after 2 weeks. The same thing in case of SAM, severe acute malnutrition, you don't do iron immediately, you do iron later. Okay, because of its nature of causing vomiting, gastritis, and all the other terrible stuff. And anyways, newborns will be having iron from the mother, the stores from the mother. So you need to supplement immediately after birth. Okay, and vitamin A and vitamin D from 2 weeks of age, you may have to supplement. Okay. Okay, coming to the danger signs and early detection and referral. Okay, what are you going to counsel the mother once you are sending the baby home, or whether you have discharged the baby from NICU? What are you going to tell the danger signs to the baby? Sorry, to the mother, that they have to observe in the baby. That is lethargy. The baby is not actively feeding. Baby is dull, lethargic, not moving actively, and refusal of feeds. So the baby is not feeding well from the breast, suckling over the breast, and there is hypothermia always, the hands are cold always, and there is tachypnea, grunt, there noisy breathing, gasping, apnea, the baby stops breathing sometimes, seizures, the baby had seizure presentation, and vacant stare, which is equivalent to seizures, and abdominal distension, the baby is feeding but there is a lot of abdominal distension, and there is bleeding, and icterus present, that is normally icterus can be present in case of newborn, but palm and soles is a serious stuff. Okay, alleged discoloration of palm and soles, so that is the baby is having hemolysis, or the baby is not feeding, being fed properly. Okay, all these things are danger signs, and you should tell the mother that you bring the child immediately to a medical center, so that the baby needs attention. Okay, then transportation of the low birth weight baby. When you say that you bring the baby, how are you going to do that? Okay, the baby should be warm properly, and life support should be there. Like if there is apnea or any sudden deterioration, somebody has to be there with ambu mask. In case of severity, you may have to intubate the baby also, so that the life support and oxygen have to be there during the transport. And most commonly, most probably, the mother should be with the baby, and there should be a referral note, like what is the age of the baby, what all happened during the delivery, and all the stuff, so that the referral center where can understand what we have done, and will save a lot of time for them to take history and examination. If there is a note, people can directly start on the management. Okay, so all these things should be there during the transport of the baby. Okay, now coming to the prognosis. After all you have done, you have identified the baby, you delivered the baby is less weight, and now you have done all the stuff. And now coming to the prognosis, what are you going to tell the mom or the parents regarding the low birth weight baby? You have fed the baby with gavage, with katori, with breastfeed and all the stuff. there is proper weight gain and all. And how the prognosis goes is, mortality is inversely related to birth weight and gestational age. The lesser gestational age, the lesser birth weight, there is a higher chance of losing the child. And it is directly related to severity of complications. Obviously that same makes sense, right? RDS, respiratory distress, sepsis, hypothermia, and all these things. If the complications are more, yeah, it is, mortality is directly related to complications. And what are the long-term prognosis of the baby? It is always depends on the birth weight. A 1.5 kg will can do better than a 1000 kg, and the gestational age, a 32 weeker will be doing better than a 30 weeker. And obviously the severity of complications. The baby doesn't have any seizures or hypoglycemia or hypothermia, all these complications. If the baby is growing well, doing the weight gain properly into the proper charts, centiles and charts, then obviously that is a good sign to have, and that is a good prognosis you can explain to the parents and the mom. Okay, I think this concludes the class. Yeah, this concludes the class. Yeah, remember that there should be more fluid intake in case of the weight low. You do more fluids because they'll be using more. Okay, not that the baby is less weight so that you give less fluid. It is less weight, so you have to give more fluids. Okay, that is the catch in this. Vitamins you supplement later after 2 weeks, and iron after 8 weeks, after 2 months. You remember like this: iron after 2 months in 2 mg per kg. Yeah, vitamin A and D after 2 weeks. Okay, yeah, this just again, this is katori, spoon, or palade feed. This is your gavage feeds, directly put a tube in the stomach and you do gavage. Okay, this is a radiant, and this is an incubator. This is a radiant warmer. It's properly wrapped, covered babies. Head is covered, everything is covered, head and both limbs are covered. This is convection, radiation, conduction, evaporation. Okay, just remember this like a mantra. Okay, KMC birth weight guidelines. Yeah, I think this should be good with it. Okay. Yeah. If any doubts, we'll do doubts. Other than that, we'll conclude the class. Yeah. Any doubts, guys? Any doubts?
No, sir.
No. A big no. Thank you. Thank you. Yeah. Thank you all for your patient hearing. Yeah. Then we'll conclude it.